How's it going so far? Good?
Good afternoon and welcome to our afternoon talk on COVID and thrombosis, a much awaited talk. And we have the fabulous Dr. Rachel Rosovsky to present to us today. Rachel is an assistant physician in the Department of Hematology Oncology in Massachusetts General Hospital in Boston and an instructor in medicine at Harvard Medical School. She is an expert and leader in the field of venous thromboembolism, and her clinical and research interest and expertise involve around the evaluation and treatment of patients with this condition. Dr. Rosovsky is a board of directors of the National Pulmonary Embolism Response Team, PERT, Consortium, and she is chair of the consortium's education committee. I am absolutely delighted to welcome Dr. Rachel Rosovsky to talk to us about COVID-19 and thrombosis. Welcome.
Welcome. I think I need to turn my, okay, that's good. I think I'm gonna, I just need to turn my Microsoft Outlook off for a minute.
Okay, no problem.
So I'm gonna stop sharing. Am I still sharing or no?
No, you're not sharing. We'll go again. Don't worry.
I'm gonna shut that down, or we're gonna get.
Okay. Everybody, this is live, so these things happen.
Okay, we're good. Now we're good. Can you see it?
Yes, perfect.
Okay. Perfect. Okay. Well, it's an absolute honor to be here, and Anne-Marie, thank you so much to you and the organization. Of course, I wish I was in Ireland with you, but this will have to do. So really an honor to be asked to speak about COVID and thrombosis. All right, so this is my agenda. I figured I'd give everybody an overview and then talk about what we've been doing in Boston, talk a little bit about management guidelines and future direction. So first of all, I think everybody is aware that COVID is a global pandemic, and really anyone is susceptible to getting it. Certainly there's higher risk populations than others, but Nick Cordera, who is a Broadway star, he was treated with blood thinners to help clotting in his leg, but then he got bleeding and they had to amputate his leg. And after weeks of suffering, he ended up passing away from COVID. So this is from Johns Hopkins, and it shows you the global cases and the global deaths. And you can see here, this was from yesterday at 1:30 in the morning, and there were 33,642 cases with over 1 million deaths. And in less than 24 hours, so you can see here, not even 24 hours, this number had increased by over 200,000 cases and over 5,000 deaths in less than 24 hours. So I thought I would frame my talk with a case that I saw. This was a 56-year-old woman who had a history of breast cancer. She had a bilateral mastectomy. She had hypertension and high lipids, and she presented to our hospital with several days of a dry cough, fever, chills, nausea, vomiting, anorexia, very tired, and she was found to be COVID positive. Now she had a D-dimer, which is a marker of clotting, and it was elevated. Normal is 500, hers was almost double. And her ferritin and something called a C-reactive protein, which are markers of inflammation, were also quite elevated. So per the protocol that we have in our hospital, she was placed on a prophylactic blood thinner, Lovenox, 40 milligrams. She was getting that every day. She also got all the COVID therapies that we were having at that time. So on hospital day 4, we noticed that her oxygen requirements started to increase. And when we looked at her D-dimer, that was increasing, as were those other markers of inflammation, her ferritin and her CRP. So you can see here, here's her x-ray, and she, these bottom little cloudy little opacities is where her infection is. And within 4 days, you can see that that has substantially increased. So the question is, what is going on? She was transferred to the ICU. And I think one of the questions we face in patients with COVID who end up getting sicker and sicker is it the COVID or is it something else? And of course, the something else that we worry about is pulmonary embolism, especially with all the literature out there that's showing that there's a very strong connection between COVID and coagulopathy. And the other question is, can we use her D-dimer to help us decide, is this pointing towards a clot or is this pointing towards worsening COVID? So actually, one of the very early studies came out of Wuhan looking at these abnormal coagulation parameters, and they found that they were strongly associated with poor prognosis in patients that had the coronavirus. So this is one of the earliest ones in February, a month after the first kind of reported cases. And you can see here that of the 183 patients, the non-survivors, which are in green, had a much higher, significantly higher levels of D-dimer than the survivors in blue. And this study and this finding has been replicated in a number of other studies. This was another study of 191 patients out of China, and they again looked at the elevated D-dimers, and they found when it was greater than 1 gram, which for us, the way we looked at it is 1,000, was strongly associated with dying in the hospital. And in fact, the odds ratio was over 18. And you can see here, the non-survivors had significantly higher levels of D-dimer than the survivors in blue. So the question then gets raised, what should we do about this? Should we anticoagulate people? D-dimers associated with clotting, we know that based on earlier studies even before COVID. And so this was also a study out of Wuhan where they looked at whether or not prophylactic low-microwave wet heparin or unfractionated heparin could benefit those patients with high D-dimers. And this was a study of 449 severe cases of COVID. And this was not a randomized control study. This was looking back. And they found that 99 patients, or 22%, were treated with prophylactic anticoagulation, and 78% of patients were not. And when you look at their mortality, it was exactly the same between the two groups as a whole comer, so 30% and 30%. But if you teased out the people that had a really high D-dimer, in fact, greater than 6 times upper limit of normal, those people actually had a 20% survival advantage, which is pretty significant. And I just want to point out that these were patients with prophylactic anticoagulation, not treatment dose. They also looked at something called the sepsis-induced coagulopathy score, and that tells you that people are really, really sick. And if patients had greater than 4, they also had that 20% mortality survival advantage, 20% less mortality when they were treated with prophylactic anticoagulation. So I think this raises the question, does that mean that we should anticoagulate everybody with COVID? And if so, what dose do we want to use? Well, we also want to think about, when we think about anticoagulating people, we also want to weigh that risk of bleeding, right? There's no free lunch here. And so this was a study that was published in Lancet Hematology back in April. Initially, we thought there was very little bleeding associated with COVID. But in this study, they tried to predict who had the highest risk of clotting and who had the highest risk of bleeding. There's something called the Padua prediction score that helps us predict who might have a blood clot. And they found that among the patients with COVID who are at the highest risk of getting a blood clot, which means their Padua prediction score was greater than 4, were actually the same people at the highest risk of bleeding. In fact, 11% of those people also had a very high risk of bleeding. So we cannot ignore this. This was a study also out of China of 82 patients, and they found that 6% of the patients died of something related to hemorrhage. And when you looked at everybody, over 80% had some kind of bleeding episode. So we cannot ignore this. And we have to balance the risks of thrombosis with the risks of bleeding. Well, I just kind of showed you the risk of bleeding. What are the risks of thrombosis? So there have been a number of studies. This is just a few that I'm bringing up here. And I want to point out a few things. Number one, none of them are randomized controlled studies. They're all retrospective, a few prospective. They're all pretty small, and they vary in terms of the population, whether they're in the ICU, whether you're screening everybody or not, and whether you're in the regular ward. The majority of patients were anticoagulated with prophylactic anticoagulation. And then I want to point out that the VTE rates are all over the map. So I want to point out this study out of New York, 393 patients. They found the rate of VTE was 7.7% in patients that were mechanically ventilated. But if you're on the wards, it was only 1.1%. If you look at this study out of France, you can see here, this was a study in the ICU patients only where they screened everybody, and they found the risk of VTE to be 69%. There's a huge difference. We have 1% and we have 69%. Since I came up with this table, there have been numerous other studies, and I'm not going to go through all these, but again, to show you all over the world, most of them are retrospective. Most of them are not that big. Most of them have ICU, ward, or both. Some of them have screening, some of them only looking if the patients have symptoms. Most of the patients were on prophylactic, was there are a certain percentage where some people were on therapeutic. And again, the rates were all over the map, 1% to 69%. So what's happening in Boston? When this first started, we were faced with a number of questions, and really the hospital needed guidance on what to do with patients when they came into the hospital and what were we going to do about their anticoagulation. So we formed a little task force that I spearheaded. And the other thing is, every week some other topic with thrombosis would come up and we would form another little group and try to answer those questions. And I'm going to go through kind of some of the projects that we came up with and have recently published. So the first thing is we wanted to look at our own data and see what are the bleeding and thrombotic rates in our own population. So we looked at 400 consecutively admitted patients over 5 different hospitals in the Boston area. 144 of those were critically ill, and almost 90% of both the critically ill and the ward patients were treated with standard prophylactic anticoagulation. And we really wanted to look at the rates of thrombosis and bleeding, but we also wanted to look at the relationship of that D-dimer and those inflammatory markers, which I already mentioned, and whether or not those coagulation and inflammatory markers could predict who might clot and predict who might bleed. So this is the summary slide, and I'm going to go over it with you. First, I want to point out that the gray is all patients, the red is critically ill, so those were the ICU patients, and the blue is non-critically ill, ward patients. So you can see here confirmed blood clots, so radiographic confirmation, all comers was 4.8%, which is more similar to that New York data that I pointed out to you. If you look at the critically ill, it was 7.6%. It's very similar to the New York one. And if you look at the non-critically ill, it was 3.1%. If you look at total VTE, now this included patients that we were suspicious had blood clot, and in fact had hemodynamic parameters that suggested that, clinical suspicion, and in fact the clinical suspicion and parameters were so high those people were put on full dose blood thinner. That's how convinced we were they had a blood clot. If you look at those patients, overall it was 6%, the ICU was 10.4%, and then wards were 3.5%. We then looked at all the thrombotic complications, including arterial blood clots, people clotting off the continuous renal replacement. Those are people that kidney functions aren't working, they have to put on a machine to replace that. Arterial lines, these were kind of all thrombotic complications, and overall was 9.5% in the ICU. Not surprising, most of these people are on these, have these arterial lines or might be on this CVVH, and that was 18.1%, and in the wards was 4.7%. Now this is what I want to point out. Major bleeding, all comers was 2.3%, in the critically ill was 5.6%, and in the wards was 0.4%. If we looked at all bleeding events, you can see here that these numbers are exactly the same as the confirmed VTE numbers. 4.8% in everybody, 7.6% in the critically ill, and 3.1%. So our bleeding and confirmed VTE rates were exactly the same. So the next thing we wanted to do was whether or not we could predict, if we could identify which markers might predict who might develop blood clots. And we found that elevations of D-dimer, platelet count, something called C-reactive protein or CRP, and ESR, which is erythrocyte sedimentation rate, both of those are markers of inflammation. When those markers at presentation were elevated, they were predictive of thrombotic complications during hospitalization. So in a multivariate analysis, we saw patients who had a D-dimer greater than 1,000 had an odds ratio of developing thrombosis of 3.0. If their D-dimer was greater than 2,500, the odds ratio was 6.8. A platelet count greater than 450, the odds ratio was 3.6. And those inflammatory markers, if they were elevated, the odds ratio was 2.7. Similarly, we wanted to look at whether or not we could identify predictors of bleeding, and we did find that there was an association of coagulation and inflammatory parameters at initial presentation with bleeding events. And indeed, if you had a D-dimer greater than 2,500, your odds ratio of bleeding was 3.6. And unlike the thrombotic high platelet count, if your platelet count was low, you were more likely to bleed. The odds ratio is 2.9. So I just want to point out again that if you look at the confirmed VTE rates in the general whole everybody and then the critically ill, it was exactly the same as the overall bleeding events. So the question is, if we're giving people more than prophylactic anticoagulation, what's going to happen to the VTE rates? Will they go down? But what's going to happen to the bleeding rates? Are they going to go up? So definitely randomized controlled trials are needed, and I will get to that in a little bit later because we do have many that are actually underway. So the other thing I said is when this all came about, we formed this task group, and we would get called periodically about thrombotic issues happening in patients around the hospital. And very early on, I was called by something called the COBRA group. They were a surgical team, and they noticed that people who had arterial lines, which are used to measure people's pressure, were all clotting off. And so we decided to come up with a protocol to try and save the life of the lines. And this was actually just recently published in the Journal of Critical Care. It was an observational cohort study because once we implemented the protocol, we thought, well, we got to test this, observe it and measure it and see if it works. It was patients over the age of 18. They were all in the intensive care unit and they all had an A-line thrombosis. And there were two cohorts. We actually developed what's called a low-dose heparinized saline protocol, where patients would get 10 units an hour through their A-line in a pressure bag. The pre-protocol, we looked at 41 patients, and the post-protocol, we looked at 30. Now, already there were patients on systemic anticoagulation, and there were patients that weren't. And you can see here, in both groups, once we implemented the protocol, the life of the A-line, so number of days before it clotted off again, or clotted, in patients before we started the protocol that were already on blood thinner, it went from 4 days to almost 14 days. And if patients weren't on blood thinner already and we started the protocol, the life of the A-line went from 2 days to almost 5 days. And you can see here, by 5 days, over 90% of the patients on the protocol had their A-lines still open and patent versus just 40% in the pre-group. And there was no difference in bleeding. So this was a real coup for us because suddenly we were able to save people's arterial lines. And I will just say that what was so remarkable about this and the next study that I'll show you is that it brought together this multidisciplinary group of people that generally don't work together. They generally don't work with the surgical team on their A-lines. But when problems like this came up, our hospital was amazing at kind of pulling together people and figuring out how to solve it. So similarly, we noticed that people with something called continuous renal replacement therapy, those were people that didn't have their kidneys working very well. We noticed that that kept clotting off. So similarly, we developed a protocol looking at heparin and following anti-10A levels. And once we implemented that with a goal dose of a higher level, we found that the filter losses decreased significantly. This was just accepted, so I appreciate it if you don't post it. So let's go to management. So I've just shared with you the number of clotting and the mechanisms and projects that we did to try and help decrease those specific incidents of clotting, but also pointed out what our thrombosis and clotting rate was. And I go back to that question is, should everyone be anticoagulated? And if so, what dose? Well, what's out there to help us? There's actually a lot of guidance documents and guidelines. This one was from the ISTH very early on, where they looked at patients, they thought that everybody that should be admitted should be started on prophylactic low liquid heparin unless there was some kind of contraindication. I will share with you our anticoagulation algorithm. So every admitted patient, we look at them and we say, are they have any contraindication to anticoagulation? So are they bleeding? Do they have low platelet count? If they do, they get what's called mechanical prophylaxis, those pneumo boots. If they don't, we ask and look to see whether or not they ever had heparin-induced thrombocytopenia. And if they did, we're going to use a non-heparin alternative to treat them. We then ask, are they already on blood thinner for some other reason, for AFib, or maybe they had a blood clot in the past? If they are, we're actually going to switch them to Lovenox. And the reason for that is because many of the COVID therapies can interact with the direct oral anticoagulants, and we didn't want to not be able to put people on clinical trials for COVID therapies if that was an interaction. We preferred low molecular weight heparin under unfractionated heparin because that decreased the amount of time the nurses had to go into the room to either measure levels of PTT or to give the shots. Unless, of course, there was a contraindication. And if patients didn't have a contraindication to anticoagulation, didn't have prior HIT, and weren't already on full dose blood thinner, everybody got a prophylactic dose of low molecular weight heparin, preferred, like I said, over unfractionated heparin. And then we also gave people guidance on dosing. There were some renal adjustments and obesity. We did increase to 40 milligrams twice a day when patients were obese. So then the question is, and we got this all the time, especially because a lot of literature was coming out with these higher rates of VTE, and people were saying, oh, we should be giving more people higher doses of prophylactic, especially if they're in the ICU, because they're the highest risk of clotting, which I already showed you they were. But we don't know if higher doses of prophylactic will decrease their risk and change outcomes. So again, looking at the guidance documents, I think there's about 10 out there now. This is from the American College of Cardiology, the ISTH guidelines, some scientific and standardization committee from ISTH. There's something called the Anticoagulation Forum came out with guidelines. Beverly Hunt in the UK has come out with guidelines. CHEST guidelines just came out, and there's all these guidelines in prevention, diagnosis, and treatment. So how do you put all these together? Well, a group of us at Mass General just actually compared all of these published guidelines for the management. So in one document, you have all the guidelines. And we asked 12 different questions, and we looked at all the guidelines to see what they said about these 12 questions. Are you using lab tests to risk stratify and triage patients? Are you using biomarkers to guide anticoagulation? Are there proposals for using more than just standard? Looking at the medications preferred, considerations for doing therapeutic, considerations for thrombectomy, decision about holding, mechanical, monitoring anticoagulation, how long, do you do it at discharge, and how do you treat bleeding? So it's a nice way to kind of look at all the guidelines. But I want to point out one guideline, which actually just recently came out in CHEST, which is the PERT guideline. So this was a position paper from the National PERT Consortium looking at how we want to diagnose and treat PE during COVID. And I just bring this up mostly because I think that case that I initially presented, we're kind of stuck with not knowing what to do with patients. And especially with COVID and the heat of it, you may not have the opportunity to actually send these people to get a CAT scan, or you may not want to expose your staff to get an ultrasound or an echo. So we came up with this algorithm that if you suspect blood clot, and you can get either a CAT scan or an ultrasound, and you can confirm a blood clot, you're going to treat them. But if you have a high clinical suspicion based on those PE probability scores, so that's like the Geneva score, the Wells criteria, and your suspicion is very high, then we did recommend that you start anticoagulation and then try to risk stratify where you think, is this a low risk PE, a submassive, massive, because that's going to dictate how to treat. Definitely think getting PERT involved, and we know from the recent European guidelines that actually using PERT to help manage these high-risk PE patients is something that should be considered and suggested. If patients have high-risk PE, massive PE, which means that their blood pressure is less than 90 for more than 15 minutes, we actually recommended thrombolysis unless it's contraindicated, but we have this little C here that says if your facility actually has the resources to be able to do something else like a catheter directed or something like that, you could go ahead and do that. But the reason we put it like this is because there's a lot of areas that don't have the resources, especially in the height of COVID. We just couldn't get patients down to these catheterization suites and expose all of that staff for things. So taking into account what your community has and institution has and really where you are in terms of your resources. So this is another nice guidance document to have to help you figure that out. So with all of these guidelines, what are providers doing? So pretty early on, I thought, what we should really do is actually survey all of the VTE experts around the world. So that's what we did. We did a global survey, and you'll recognize this name and you'll recognize this name. two of yours. And so we really wanted to see what are VT experts doing around the world in terms of anticoagulation practices during this time, especially because we don't have randomized controlled trials. So this was a global survey. We know that VT events are possible complications of COVID, and their management protocols are really undefined. So this was how are doctors around the world dealing with VTE patients at the time of COVID. This was a 28-question survey about the current approaches to prophylaxis, diagnosis, complications of VTE with COVID, administered to physicians worldwide. We had over 500 participants from 41 different countries, which was really incredible. And we found that 78% of the respondents recommended prophylactic anticoagulation for all hospitalized patients. And I've already showed you some data about that. And when we looked at when patients would increase that anticoagulation, as you can see here, that patients who were in the ICU with that D-dimer greater than 6-fold, people would increase to intermediate and therapeutic. But I want to point out that that study that I showed you, those people were only on prophylactic anticoagulation. But again, this was the percentage of respondents who recommended escalating anticoagulation. So I will point out that over 25% of people said they never increased to intermediate dose, and very few actually increased to the therapeutic dose. Very few people would not do that. So in the ICU, over 30% were doing intermediate dose. Obese patients, over 25%. And if they had an additional risk factor, they were increasing to intermediate dose. But I point this out to kind of show you it's really all over the map, right? We really don't know what to do, and people are doing all sorts of things. We also noticed that compression ultrasound was recommended for 80% of people if they had clinical symptoms of a deep vein thrombosis. 17% were getting ultrasound just based on that D-dimer result, and 8% of the respondents were getting an ultrasound for every single person in the ICU. What about bleeding complications? Well, 54% of the respondents said that they didn't see any bleeding complications. 34% saw minor bleeding complications. 14% clinically relevant non-major, and 12% saw that major bleeding. And the respondents who estimated VTE, 44% chose to answer this question. And look at this, the thrombosis was estimated anywhere from 1 to 50%, which is exactly what the literature shows you, 1 to 69%. So you can see here in this figure, these patients who reported incidents of thrombosis, hospitalized and ICU patients. And this figure really represents the estimated incidence of thrombosis reported by each respondent. And you can see here that most people, first of all, over 50% didn't, said it was unknown. And then here's the various estimates, 1 to 5, 6 to 10, 11 to 15, 16 to 19. Most people had the number go down in the ward, and most people saw that the number was going up in the ICU. So this survey, I think, really outlines the current VTE management practices for hospitalized patients with COVID and brings to attention the need for really well-conducted epidemiology studies and clinical trials. I think that is essential. And I've already told you that the guidance is out there, but it's rapidly changing. There is some consensus data. I've already shown you some of those. There's also resources. You can go on the ASH website. ISDH has excellent resources as well. But we really need more data, and we really need clinical trials. So about 2 months ago, when I looked up clinicaltrials.gov and I put in COVID and anticoagulation, there were 13 studies. I did this yesterday. There are now 42 studies. So this is just an explosion of people really trying to figure out this question. And we should, because I've just shown you that how people are treating patients is all over the map. And the retrospective and few prospective studies that we have, again, the numbers are all over the map. So we really need randomized controlled trials looking at, intermediate versus prophylactic dose anticoagulation, full dose versus intermediate versus prophylactic, because we need to know who is going to benefit best from these higher doses of anticoagulation and at what risk. So going back to our patient, just transferred to the ICU, this question is still, could she have a PE and should we increase her anticoagulation? So what we found was that her oxygen status worsened and she needed more oxygen, but she was hemodynamically stable. Her heart rate was stable. And even though the D-dimer had increased, it increased a modest amount. And we felt more confident that this was her COVID and not a PE. She was too unstable to get a CAT scan, so we actually kept her where she is. Given that there's no evidence that increasing the prophylactic dose of anticoagulation improves outcomes or decreases the risk of thrombosis, I should say, we didn't do it, and she actually recovered and did well. I will say, and you can look at the PERT guidelines for this, in patients who you really, again, you're stuck with, okay, increasing oxygen requirement, in those patients who have other symptoms to suggest they have a PE, so for example, you look at the X-ray and they don't have worsening opacities and their blood pressure is going down and their heart rate's going up, that to me speaks to more of a PE. But if I have a patient that's doing poorly and they have a whiteout of their chest X-ray, I'm going to think that's more likely to be the COVID. But you don't know for sure, and obviously trying to get the imaging is the best idea. And if you can't, it's really that art of figuring this out. So what can you do? Well, you can wear a mask, wear a mask, wear a mask, wear a mask, and social distance. Most important. And really know the signs and symptoms of a deep vein thrombosis or pulmonary embolism. It's all about awareness, and I want to give a plug for that. So my closing reflections are that COVID-associated coagulopathy is real, and that the rates of thrombotic events have varied dramatically in the published literature so far. I think we can all agree that prophylactic anticoagulation should be used for all hospitalized patients. What do we do for patients that are not sick enough to be hospitalized? What are we doing for discharge patients? I think that is still unanswered questions, and there's clinical trials now ongoing that are going to look at that. And these well-conducted clinical trials are so needed. Definitely know the signs and symptoms of a blood clot, and definitely be aware of that. And then I want to end with my own personal experience with COVID. So we are a very busy hematology oncology practice at Mass General, and we treat more than 5,000 patients a year. And we suddenly had to convert our very busy inpatient oncology service to a COVID service. And this is a article that Carrie Reynolds, one of my colleagues, is the first author on this. And it's really a story of teamwork and resilience. And I think I just want to briefly mention, so in early March, our hospital saw that we were going to have a dramatic increase in the number of inpatients and ICU beds that were going to be devoted to COVID-19. And it followed that we would need a similar dramatic increase in staffing to cover this surge of patients. And we were asked to step in and do this. So I'm a hematologist. I am not an infectious disease person. I'm not a hospitalist. I'm not an intern. I'm not a resident anymore. So on top of needing kind of that intern 101 refresher, we also had to rapidly learn this new ever-changing language of the COVID-19, identifying risk factors, categorizing patients with severe disease, determining when to use what drugs, treating co-infections, discussing all the antiviral clinical trials with patients, all while trying to understand that there's so much that we just don't know. And honestly, one of the biggest challenges was fear. We were fearful of becoming infected ourselves, fearful of transporting the virus back home to our families, fearful of patients coughing and sneezing on us, fearful of touching anything without our proper protection. And the fear was pervasive, and at times it was paralyzing. But I have to say, in our group, there was not one person who didn't have a compelling home situation or personal health exception that declined to participate. And at the peak, we staffed several units day and night. There were 94 hem-onc specialists who covered over 750 surge shifts. And, at the outside, we didn't say, how well are we suited? We certainly didn't feel suited. But as physicians, I think we attempt to marry compassionate care and up-to-date research, and we encountered multi-organ involvement, regularly saw patients in critical conditions. But I think our experience as hem-oncs really translated well into our taking care of these patients. And I think we usually deal with unknowns and have to adjust and consider alternative medications. So really, I feel like it's an art of science and medicine, and we really tried to guide our patients and their families through these incredibly trying times. And I will say, I just want to go over some of the quotes in the article. It was humbling to take care of patients with COVID-19. More than ever, we needed compassion and emotional connectivity with our patients and their families battling these devastating and isolating disease. The scope and manifestation of COVID-19 symptoms were overwhelming. COVID-19 is marked by relentless loneliness and fear. These emotions are experienced by individuals, families, communities. In the face of this, we mobilized our best skills in oncologists to provide individualized and compassionate care while supporting each other as colleagues and friends. Wearing PPE was exhausting, and it required constant vigilance. For patients with COVID-19, it's often a helpless feeling. There are no effective treatments, and you feel you're not doing enough. And the only more formidable than fear we faced over the last several weeks is the overwhelming sense of compassion, connection, and teamwork. And Carrie had one of her friends do this, which I just think is absolutely beautiful. And this is the slide of the hem-onc faces. And on June 10th, it marked the end of our surge effort and a time to reflect on the previous 83 days. And it really was truly a team effort. Physicians from all disciplines, nurses, nurse practitioners, residents, fellows, interpreter services, environmental services, dietary services, patient transport, administrators were all critical. But I really feel that this experience made us better, stronger, and more human. And by employing the art of hematology oncology, we really helped in a time of great need and remain prepared for whatever the future may bring. And I'll just quote her. So we now know that together we can face danger and an enormous uncertainty and still find safe harbor on the other side. So I think VTE Ireland bringing us all together is doing the exact same thing. And I just want to thank everybody and end by saying, definitely take care of yourself. So thank you so much for having me. And you can go on our Mass General website if you want specific treatment guidance documents. So thank you, Anne-Marie.
Oh, thank you so much, Rachel. That was really, really interesting. I just have a couple of questions. If you have thrombophilia, or antiphospholipid or CVST, are you more at risk of dying if you get COVID? Are you higher risk of that serious ending up in ICU?
So we don't have any data that suggests that at all. So no, there's no studies out there that say if you have factor V Leiden, you're more likely to get sick if you get COVID. We do know, if you look at a lot of those guidance documents, there are a lot of people that say if you do have higher risks and you end up getting it, the question is, what do you do? So again, anybody that's being hospitalized, they're getting prophylactic anticoagulation. But if you also have additional risk factors for, let's say, VTE risk factors, should you get more than just prophylactic anticoagulation? We're not doing that in our hospital. There are some people that are doing it. I think it's on an individual basis, and you really need to talk with your doctor about that. Because, if you end up in the ICU and you've had, 4 blood clots in the past, I'm probably going to put that person on a higher dose,
Okay, yes.
that might push me up the edge. But, just having thrombophilia alone, there's no data to suggest that you are going to fare worse. We do know that there are risk factors for people, high blood pressure, older people, obesity, immunocompromised people. But yes, thrombophilia in and of itself has not been a marker that portends worse prognosis.
Isn't that good news for this particular conference anyway? Are you seeing an increase in returns of COVID patients that were hospitalized, they're back out in the community, and then they're presenting again with VTE?
So that's a really good question. There's actually been a study that was recently published, actually a study that was published at, was presented at ISTH, where they look, oh, I just lost you, where they looked at patients who were discharged, and then they looked at the rate of recurrent, people that are coming back with DVT and PE, and the rate was very, very low. I believe it was 0.8%, if I remember correctly. So it was very, very low. So I think, but the question of whether or not discharged patients need to be put on prophylactic anticoagulation is an area of debate. And fortunately, there's going to be a study that is going to be started that's going to look exactly at this, because at this point we don't know. We do know that at this point, if you look at all the literature, the patients that are at the highest risk of getting the blood clots are the patients in the ICU. Then the patients in the wards have a much lower rate. So what's the rate in the community? We actually don't know, right? So if you get sick, but you're not sick enough to be in the hospital, what's your rate of blood clot? We don't have that data. We don't know that.
Well, we do know that people are are at a higher risk just by virtue of being in hospital. And we also know that if you've had COVID and been hospitalized with COVID, there is an increased risk. So then to me, it would surmise that the people who are hospitalized with COVID, to me, it's a no-brainer that they should be anticoagulated for those 90 days, at least for those risk times. There's no conversation here about that. And I'm just interested.
So let me just clarify. Patients that are hospitalized with COVID, yes, they should get prophylactic anticoagulation. You are exactly right. There's a high risk of getting blood clot. I think across the board, I think unless there's a contraindication to prophylactic anticoagulation for anyone admitted to the hospital, that should be done. Yeah. The question is, if they get a blood clot, then they need to be put on full dose blood thinner and they need to be treated for at least 3 months, longer if there's ongoing risk factors. But if they're in the hospital, let's say they're in the ward, they get their prophylactic anticoagulation and they get discharged home, there's no trial right now that says they should go home with blood thinner. There is a trial that's starting to look at that. We don't know the answer to that question. And the problem of just doing it to do it is that we don't know what the recurrent clot rate is, although I just showed you from that ISTH study that it's very low. But we also don't know what the bleeding rate is. So it's important to understand that anticoagulation is not without risk. And so we really need to weigh those risks and benefits. So just the fact that you were in the hospital with COVID does not mean that you suddenly need to be on blood thinner for 3 months. If you've had a blood clot, yes. But if you are hospitalized with COVID, you should be on prophylactic anticoagulation. When you get discharged, a lot of the guidance documents say if you have risk factors for getting a blood clot besides being hospitalized in COVID, that would be a conversation to have with your provider about whether or not you would need to be put on a blood thinner when you get sent home.
Okay, that's fair enough, but they should at least be informed 100% of the possible risk and then the signs to watch for, you know, just to put them on guard, I think.
So I just want to pick up on what you just said, which are know the signs and symptoms, right?
Yes.
So if you develop, you know, leg pain, leg swelling, you know, redness, especially if it's unilateral, meaning one leg, and it's just kind of out of the blue and it doesn't go away, or you suddenly get chest pain, chest pressure, shortness of breath, that's new once you get released from the hospital, or if you have it at home and it gets worse, definitely you want to seek medical attention. And again, the problem is, you know, a lot of the signs and symptoms of COVID are the same ones that you could have with pulmonary embolism. So instead of trying to figure this out at home, you want to get your provider to help you tease that out.
Always get checked. Just on a separate note completely, are you capturing thrombosis patients that are not admitted? So that just come to A&E, like emergency room, that maybe are put on a dog and sent home. This is separate to COVID. It's just a thrombosis question.
Oh, I'm just wondering, COVID patients.
Yeah. In your data, are you capturing those patients that aren't admitted?
Not COVID patients. You're just talking about everybody who comes to the hospital and has a blood clot. So that's a really good question. There's we actually have a program that we started about 5 years ago at our hospital, where patients that were coming to the hospital with signs and symptoms of a blood clot, and if it was, you know, a deep vein thrombosis or a low risk pulmonary embolism, we thought they don't really need to be hospitalized, right? Like not everybody needs to be hospitalized. And so we asked our ER docs, why are all these people being hospitalized? And the main reason was litigation. They were afraid to send them home in case something happened, they would get, you know, sued or in trouble, whatever. So we came up with a program where when people come into the hospital and they get diagnosed with a blood clot and they don't meet criteria for needing to be admitted. So that would be their vital signs are okay, they have good enough social support, they don't have any other comorbidities that would, you know, cause us to want us to admit them, meaning they had normal renal function, they didn't have cardiac disease, their lab tests all looked good. If they met criteria for being able to be treated at home, we set up a program where within 7 days they would come to our hematology clinic and be seen. And we always called the primary care doctor and said, do you want to see them within 7 days? Or we have this new program and you can have a specialist see them within 7 days. And we then looked at the number of patients being admitted versus being discharged. And once we implemented the program, there was about a 25% increase in the number of people being sent home, which is huge. You can imagine better quality of life.
So are these people that aren't admitted captured in your data of occurrences of VTE in your hospital?
Yeah. So then what we did is, that's a really good question. So then what we did is we're sending them home. Are they coming back? And we found no, that there was no change in the number. Nobody came back with recurrent clots. There was no bleeding, things like that. So we definitely looked at the outcomes, and we found that we found that they were not detrimental. Okay. So that's a very good question, and that's really the main thing. Where are people coming back with recurrent clots? Are people coming back with bleeding? And no, I did not find that.
So, you know, when somebody presents, sorry, I know I'm monopolizing the time, but I'm really interested in this question to see how you do it. If they present at your hospital for the first time to ED and are put on a DOAC and are sent home, yes, they come back 7 days later, they're on your program. But when your hospital shows their data for occurrences of VTE, you know, the amount of VTEs that they see in their hospital, are the people that aren't admitted included in that data?
Wait,
are the patients that aren't admitted with VTE?
Yeah, those are the people.
Data. Yeah. So is that collected in the emergency room, that data?
We collected that. So this was a clinical trial. We actually published it about a year ago. I can send you the published paper. Yes, that's exactly what we had to look at that. So in order to prove that our program was safe and effective, we took everybody who came in with a blood clot, everybody, whether they were admitted or discharged. Right. And then we followed them and found out who bled, who had recurrent clot, who came back to the emergency room. And there was, with the program in place, there weren't any complications like that happened.
That is fantastic, it really is. I like the fact that they come back in 7 days. It kind of soothes the anxiety as well, because when you go home, you think about it and then you go, oh my God, am I safe? You know, I think I like that idea.
And one of the main things about that is that we learned some quick lessons in that. Number one, they couldn't leave the emergency room without drug in hand, or someone had called their pharmacy and the drug was going to be waiting for them, because you know, we found that unless they have the drug in hand, and we actually gave them a month's supply, so they actually had a month to follow up with it. We usually saw them within a week or 7 to 10 days, but that was very important, because you send someone home and you say, go pick up this prescription, but you don't know if their insurance is going to cover it. You don't know, you know, are they going to, does the pharmacy have it? Do they know how to take it? Things like that. So that was really
important. Realize how important it is that they start taking it immediately
and know how to take it. So we had a you know, wonderful case manager and social worker helping us.
Yeah. Okay, that's fantastic. I better move on to the next talk. Thank you so much, Dr. Rachel.
Oh my gosh, thank you so much for having me.
It was brilliant. And
sharing. Oh, there you go.